Hello, everybody, and welcome back to the MBME 26 series, where we explain every single question of MBME 26. My name is Blake Young. I graduated from Harvard, and I have 7 years of tutoring experience, and this YouTube channel is my effort to make studying for medical school super easy. If you want to follow along at home, we're covering MBME 26, and we're currently on Section 2. We just finished the first 10, so now we're going to do 11. These are not the actual MBME questions. I have made these questions. They cover the same topics and material that you'll need to know by the time you finish MBME 26, if you get what I'm saying. So pop that popcorn. Here we go. MBME style question 11, part 2 of MBME 26. We have a researcher studying the mechanisms of airway tone in isolated bronchial smooth muscle strips. Upon examining, she sees a marked decrease in contract force. The compound binds to a receptor that activates GS protein coupled pathway, which of the following best explains this observed effect. On this channel, I like to explain everything super simply. So I'm going to make a little diagram that illustrates the receptor-specific signaling pathways that are activated by the correct answer to this question, prostaglandin E2 or PGE2. And this is going to have like a downstream cellular effect, particularly in osteoblasts, but the same G protein concepts are going to apply to smooth muscles, immune cells, and other things. And so we have this thing called a ligand, and that's where PGE2, prostaglandin E2 comes in. It's a lipid signaling molecule that binds to the EP receptors. Okay, so what are these guys? EP1, EP2? No, this is not episode 1 and 2 of Breaking Bad. You got to put that on pause while you're doing dedicated period. These guys are the receptors, and they have different coupled pathways. So let's look at EP1 here is coupled to PLC gamma phospholipase, that's phospholipase C gamma, and that will just increase the calcium. And then calcium leads to the activation of kinases, and then kinases have transcriptional changes, and those lead to biological effects like osteoblast differentiation. So in smooth muscle cells, an increase of calcium is going to promote your contraction. Let's look at this guy, E2, your EP2, your EP4. These guys are coupled to GS proteins, and so they activate adenylate cyclase. The effect is increased CAMP. What does increased CAMP do? Well, that activates protein kinase A. So now we've activated protein kinase A through CAMP because we activated our receptor through PGE2. PKA will then go along and phosphorylate CREB. Why is it called CREB? That's such a weird name. Like this video if your name is CREB. Well, CREB stands for the CAMP response element binding protein. And CREB is a transcriptional factor. And so that triggers your genes for cell survival and proliferation and differentiation. And so in the bronchial smooth muscle, PKA inhibits the myosin light chain, and that causes your relaxation. I'm just showing you how this all works. It's pretty much always the same. We have GS proteins, they activate adenylate cyclase. The effect is increased CAMP. CAMP activates PKA. PKA phosphorylates CREB, like if your name is CREB. CREB is a transcription factor. It triggers the genes for cell survival, differentiation, and then in the bronchial smooth muscle, what you need to know is that PKA inhibits myosin light chain kinase, so it causes relaxation. So smooth muscle contraction occurs when your myosin light chains are phosphorylated, right? Because then you get your cross bridge formations between your myosin head and your actin filaments. This reaction is facilitated by myosin light chain kinase. And what do you think opposes it? Well, it's myosin light chain phosphatase. And then in this question, we're talking about PGE2. Why? Because that stimulates adenylyl cyclase in smooth muscle cells, and that leads to an increase of CAMP inhibits the activity of myosin light chain kinase. And so you decrease the phosphorylation of your myosin light chains. It just helps you just chill out. So your myosin light chains are trying to be cross-bridging. They're trying to be activated by their kinases. And in this question stem, we have a GS protein coupled pathway, something that mimics like PGE2. It's just inhibiting that kinase, leading to no cross-bridge formation, rather relaxation. And that, my friends, is bronchodilation. So the trap answers were activation of phospholipase C, but that would be the opposite effect, increased contraction because of your increased intracellular calcium. Closing of potassium channels, that would also lead to contraction. Anything that promotes calcium influx will lead to contraction. Stimulation of guanylyl cyclase, that's a different path, not your PGE2 in the airway. Inhibition of myosin light chain, well, if you're taking away the phosphatase, then it's going to be sustained contraction. The phosphatase kind of has the same interaction as like inhibiting that kinase, the MLC kinase, which causes the cross-bridging. So before we move on, let's just recap what we now know. Your lungs, they can relax on command thanks to prostaglandin E2. Woohoo! PG2. That induces bronchodilation by hijacking your smooth muscle cell signaling machinery. Cells are comprised, you have your ligands, receptors, kinases, transcription factors, and then the effect on the body. So when PGE2 binds to the EP2 or EP4 receptors on bronchial smooth muscle, it activates a GS protein. That revs up adenylate cyclase, which then revs up your cyclic AMP, right? The spike in the CAMP then goes straight to the heart of the muscle contraction, and it shuts down those myosin light chain kinases. It's like, you guys are having a party here? Not anymore. Shuts them down. That causes relaxation. So in our question, a researcher observed reduced contraction after applying a GS-linked compound, Well, reduced contraction, less kinase, less cross-bridging. PGE2 certainly does that, and it does that through CAMP. Why? Because CAMP says, hey guys, time to camp it up. Yes, sir, because the MLCK is blocked, the myosin light chains aren't phosphorylated, and so the actin-myosin cross-bridge cycle can't proceed, and you get relaxation. Now, let's compare this with thromboxane. That does the opposite, right? That activates IP3 to release intracellular calcium. And intracellular calcium is going to rev up that kinase. That'll cause more cross-bridging. So you have reduced after applying a GS, so it's going to be the CAMP activation. And the CAMP is going to be stimulated through the EP2s, EP4s of your PGE2s. All right, that was your first question of part 2 of MBME 26. Moving on to the next one. We'll just zoom in right here. I'll call this one question 12. Look at that. A friend of mine recently took the STEP exam, and you need to know this. As of 2025. Okay, so herpes, what does this do? It causes genital ulcers, cold sores, and how does it act? It's latent in your neurons. Thymidine kinase, that's a viral enzyme that phosphorylates prodrugs like acyclovir. And so we use guanosine analogs like acyclovir, and those require thymidine kinase for their activation. So if you have resistance, you have the loss of the viral kinase, and then the drug will fail to activate. Now, before we proceed, I've gone through first aid, and I'm going to tell you everything you need to know about thymidine kinase. There are only like 4 things, but you have to know all of these by testing. There's no way around it. So all of these VIRs, these analogs, they're phosphorylated by HSV thymidine kinase and not phosphorylated by uninfected cells. Now, the thing is, there's no activity in clinical situations against your CMV because CMV lacks what? CMV lacks thymidine kinase, and that's necessary to activate your guanosine analogs. And so there's no activity against CMV because CMV does not have thymidine kinase. So HSV and VZV, you do have activity there. They're going to monophosphorylate the thymidine kinase. And then for herpes zoster, you're especially going to use the FAM. I like saying, hey fam, I got herpes, like I'm confessing to my family. And so you can have a mechanism of resistance, and this is the second thing that I want you to know. So the first thing is just guanosine analogs. That's the first thing. The second thing is, if you mutate the viral thymidine kinase, that's a mechanism of resistance to these drugs. So thymidine kinase is super important if you're treating HSV, and it's very important to associate them with these drugs. The next thing I want you to know is there's this other thing called ganciclovir. That's a guanosine analog, and ganciclovir is especially going to be used for CMV, especially those who are immunocompromised, right? And it's going to work through the viral kinase, so a little bit different than the thymidine kinase, but still it's a guanosine analog, but it works with CMV. And so your mechanism of resistance, the fourth thing you need to know for this drug, is going to be mutated viral kinase. And that's everything you need to know. That's all that's in first aid about this. So the pathophys, HSV infects the epithelial cells. Acyclovir enters and phosphorylates it. Then it gets converted into acyclo-GTP, incorporated into viral DNA, chain termination, no viral replication. It's a beautiful thing. All right, so our practice question, we have a 29-year-old woman presenting with painful clusters and vesicles in her labia. She is diagnosed with genital herpes, and she's put on an oral antiviral therapy. Her symptoms resolve. Yay! Which viral enzyme was critical and super easy now? Obviously, it's thymidine kinase because we have a guanosine analog that's used to treat HSV, and it requires this. Recent friend of mine, still a friend of mine, recent test question, thymidine kinase. Okay, let's look at these other answer choices. This is going to be your influenza virus. So it works with oseltamivir, Xana, not with HSV, totally different. DNA polymerase, that's the target, right? It's not going to be the activator. Protease, so that would be involved in HIV. I have a video on that, but this is herpes, not HIV. Same thing with, integrase that would insert into the viral DNA into the host genome is what integrase does. And that's seen in HIV as well, but it's irrelevant for HSV. So those are the key features. And so the big takeaway here, to make this very simple, herpes medications only work in cells that are infected. It's because of unleashes that thymidine kinase and it phosphorylates the drug. And then it converts it into a triphosphate that then sneaks into the viral DNA. And it gets incorporated, and then boom, we have chain termination. Say it ain't so. That's right, we have chain termination. And that's the reason why the answer is D. That's the linchpin that gets activated in the medication. No kinase, no killing, right? And so that explains the resistance, right? So if HSV mutates and loses its thymidine kinase, then these drugs will stop working. And so I just love how we invent drugs. Like humans are so cool sometimes. We target the virus's own machinery, and then we make it do, the dirty work for us, causing chain termination. I don't know why I'm saying it like that. Okay, next question. We'll call this one 13. Wink. If you know, you know. And if you don't know, I'm sure somebody in the comment section will tell you why I'm calling this one 13. Yeah, that's all I'm going to say about that. Wink. Now we're going to talk about something that I knew virtually nothing about until I went to medical school. So we were talking about the endometrial cycle, and you have your FSH that stimulates follicular development, and it ends with ovulation. And then you have your luteal phase, which then will be 15 to 28. And that begins after ovulation, dominated by progesterone from the corpus luteum and it prepares the endometrium for implantation, and it ends with menstruation if there's no pregnancy. So the cycle goes, first we have the menstrual phase, days 1 to 5. Then you have the proliferative phase. This is 6 to 14. Now what drives this is actually going to be estrogen. Until you have regeneration of the endometrial lining, estrogen is going to establish that. And so histologically speaking, you are going to see straight glands. You have mitotic figures, and there's going to be growing spiral arteries. You're establishing, you're proliferating. Then we go into the secretory phase. That's 15 to 28. And that's going to be driven by progesterone. Look at that. And what does that do? Well, that prepares you for implantation. Histologically, you'll have the tortuous glands, and you have like fully developed spiral arteries. Okay, so that estrogen is really just establishing things. You get the straight, you get the mitosis. Then the secretory, it maintains it, protects it. Estrogen establishes, progesterone protects, and then proliferative is really going to be estrogen, which is like the builder. And so menstruation is a withdrawal bleed from the drop of progesterone. Because this is eventually, it can't stay there forever, so it drops and you have your menstrual bleed. So in our practice question, we have a 29-year-old woman undergoing fertility evaluation with endometrial biopsy performed on day 13 of her 28-day cycle. Histology shows straight tubular glands, proliferating stromal cells, and early elongation of spiral arteries. Which hormone is responsible? Estradiol. It's driven by estrogen from the maturing ovarian follicle. Hopefully we explained that pretty well, but the big picture that you need to know as a future clinician, as somebody who's going to pass this silly exam we call step 1, which does not at all determine anything about how well you'll be performing as a doctor, but whatever, the system's broken. What can we do? When you look at a piece of uterine tissue under a microscope and analyze it histologically, you can actually pinpoint the day of the menstrual cycle within just a couple of days. And it's all about the shape of the glands and the status of the stroma, is the supportive tissue of the epithelial organ, tumor, or the gonad. So it consists of your connective tissues, your blood vessels, that stuff. And so what drives that is estradiol. It's a form of estrogen that's produced by the growing ovarian follicle. So estradiol stimulates the regrowth of the endometrial lining before menstruation. And so this straight glands are going to be a dead giveaway histologically. And when ovulation happens, progesterone is going to take over. And that will then transform the endometrium into a nice little home. And that is the reason our answer is going to be estrogen. Hopefully that makes sense. Once again, I have 5 brothers. I knew none of this before coming into medical school, or at least so little that I'm embarrassed to say. But it can be confusing until you realize that these are the 3 main phases, proliferative, primarily driven by estrogen here. You'll see like signs of growth in the straight glands, and then progesterone is going to protect it afterwards. So yeah, the proliferative endometrium is present during the proliferative phase, and that's all she wrote. Next question. We'll go over here. We'll call this one 14. Somebody told me I'm really bad at winking. I don't know. So here we have a 3-year-old girl, and she presents with confusion, vomiting after she skips breakfast. Sounds like me, honestly. I just had a banana this morning. However, exam shows hepatomegaly, and the labs show decreased glucose, decreased ketones, increased dicarboxylic acid in the urine, and decreased serum carnitine. After IV dextrose, she improves rapidly. Which enzyme is deficient in her? It's long-chain CoA dehydrogenase. We have a fatty acid oxidation defect involving the long chains, LCAD. That deficiency explains the hypoglycemia, acid, low carnitine, and fat. Okay, so high level, let's make this super simple. A baby can't use fats for energy during fasting. So when you don't eat like overnight or during an illness, your body switches from using glucose to breaking down the fats for energy in a process that's called, you guessed it, you was right, beta oxidation. All right, and why do we do that? Well, we need ATP. And so we get it from the fats. We also from acetyl-CoA to your ketone bodies, which are used by the brain and the muscle. And so if you can't break down long-chain fatty acids, then you run out of energy really, really quickly. And that's what happened to this baby who skipped breakfast. And so your baby's going to have, confusion, lethargy, hypoglycemia. But then they respond whenever you give them IV glucose. They just light up again, right? Why? Because that gives you immediate energy. Why? Because it's medium-chain triglycerides. This bypasses the defective enzyme, which is the long-chain LCAD. And so our medium is a different mechanism, right? That bypasses the defective mechanism. Medium chains don't need the long chain enzyme, and so the baby can still use these, right? So glucose is processed through your medium chains, and the long chains are done with the beta oxidation for your fats. And so we hinted at this before, but LCAD, that's the first enzyme in beta oxidation. When it's deficient, you have no ATP, no ketones, and so you have fasting that leads to a coma, confusion, death. And so for step 1, you'll need to look out for this if you're seeing a little baby who's fasting, not eating, vomiting, illness overnight, sudden lethargy, coma, seizure, or death, hypoglycemia without ketones. No ketones. Can't make ketones without the long chain. So this is an inherited enzyme deficiency. And now you might be thinking, okay, that's all well and good, Blake, I get it. But on test day, they're going to confuse me. How do I know it's not normal fasting, Blake? Well, good question, Blake. Glucose is decreased, yeah, but your ketones would be increased in normal fasting, right? A healthy person just burned the fat for energy. And so the ketones, that says ketones, by the way, are increased in normal fasting. But Blake, how do I know that it's not like some other deficiency, like Von Ger, as I called it all through my M 1 year, Von Gerties? Well, same thing. You can still make the ketones, you just can't release glucose, but you can burn the fat, right? And that's why we know it is a fatty acid defect, because we have decreased glucose and also decreased ketones. You can't use the fat. No glucose, no ketones. Now, just clinically, MCAT. Oh, we just launched our MCAT, by the way. So Board Buddies works for the MCAT too. So if you guys are preparing for the MCAT, know a friend, let them know. Always message me, guys, if you can't afford needing the software. I'm not doing this to make money. I'm doing this to help you guys out. Also, if you want tutoring, just let me know. I employ 30 part-time employees. They're all from Harvard, so they can help you out. That's why I'm wearing this horribly pretentious shirt. Okay, I digress. You don't need to know the chain type. That doesn't really matter. But the common clue is that this is going to be screened at birth. So in your practice later on, you'll be able to catch this like pretty early. And then like LCAD, it has like a different chain type, but you have really severe episodes and at later onset typically. And then if you have like a carnitine shuttle problem, like a CBT2 defect, then that would be one of your long chains. And that could have muscle weakness and rhabdo in teens and adults. The onset is important for you to think about clinically. When is this happening could really key you into different diagnoses. Really, the big picture here and how you can not miss this on test day to really just dial in if you weren't even listening or you just were doing push-ups, you're like lifting weights or something, and now you're back, you're locked in. Well, what you need to know is ketones missing, you got a fatty acid oxidation defect. That's what I want you to know by the time you finish MBME 26. Question 13, because now we're on 14. Also, I made that pretty big. Looks like we're gonna fill up all of this by the time we finish this exam. Like and subscribe if you're into that. We are on question 15. So for question 15, we have a researcher that is studying the epigenetic regulation of gene expression. She finds that the treatment with a certain compound causes increased expression of multiple previously silent genes. The compound is later shown to acetylate histone lysine residues. Definitely one of your positives, right? Man, I still remember all of those from the MCAT days, amino acids. What is the most likely effect of this modification? So this is all about acetylation, right? And acetylation of lysine, it says here, neutralizes their positive charge, weakening their attraction to negatively charged DNA, loosens the chromatin structure, allowing transcription to bind. If the trap answers then I'm going to explain this in my own words here. Promotes histone removal. Acetylation alters interaction, not removal. Just alters, doesn't remove. B, increased methylation, that would repress it. You methylate, you're constricting it down really tight. Increase histone binding, deacetylation, that increases histone DNA interaction, restoring your positive charge. Nucleosomes stay intact for the inducing of nucleosome disassembly. Acetylation just makes them more accessible. So the way to think about this is you got your windy DNA. And so histone acetylation is when you have your chromatin unwinding, euchromatin. If you guys check out First Aid, it's like one of the first book. I know this because like over the summer, I would sometimes be like, I'm going to learn the whole First Aid. And then I would keep reading like that page, just never getting past it. You can do it. But yeah, so increased gene transcription by decreasing DNA histone affinity. So your histones, they're loving it. They're having a good time at the party. They're just binding super tight. And then histone acetylation is like, guys, chill, daddy, chill. That's what it does. And it relaxes that chromatin, right? It switches from hetero to euchromatin, and it will increase the transcription. That's what we need to know about acetylation. So histone acetyltransferase, there's a nice word for that, HAT. So I love computer science stuff, as you can tell in the background. HAT is also an amazing file that you can download to hack your Nintendo Switches. But here it's histone acetyltransferase, and that adds your acetyl groups to lysine, and it opens the chromatin. There's also histone deacetylase. And you don't really need to know this, so I'll do this super fast. That removes acetyl groups and closes the chromatin. And then you do need to know this. Euchromatin, that is active, and then heterochromatin is silent. Lysine is positive, DNA is negative. They get a bind. And then histones contain positively charged lysine, right? So histones, super positive in their N-terminal tails. And they bind to those negatively charged phosphate backbones of the DNA. Because you know the DNA backbone, all of you guys have done the MCAT already. If you haven't, I'll make a new channel for that. But lysines bind tightly to the negatively charged phosphate backbones. The backbone of DNA has all these like phosphates on them. Anyways, so yeah, it's a way of activating your gene transcription. And so the turning on and off of genes, the takeaway that I want you guys to get from all of this, the turning on and off, that's just how tight your DNA is packed. That's all it is. And you can flip that switch with an acetyl group. And that's histone acetyltransferase, HAT. It adds acetyl groups to lysine residues on histone tails. And so normally your lysine carries the positive charge and it clings super tight to the negatively charged DNA phosphates. And so it keeps it wound up as like inactive heterochromatin. And then once it's acetylated, lysine loses its grip and then the histone will weaken and the chromatin relaxes and opens up euchromatin. And now it can do transcription. Okay, hopefully that was helpful. Moving on to question 16. By the way, I would love it if you give me some feedback, things you want to see over here. If you guys hit subscribe, this will actually change and it'll go boom. it'll light up because I built a server that will get all of your subscriptions and it like flashes every hour that I get a subscriber. So if you want to just like wake me up randomly in the night at like 3 a.m., then just like wait until 3 and then just subscribe. Okay, 16. By the way, some of you guys who are wondering what you should do with your phones whenever you're studying, you should do this. Ready? Put it on silent, throw it across the room. Question 16. 62-year-old man with COPD presents with increasing leg swelling and fatigue. His respiratory rate is 18. There's a prominent thrusting impulse is palpated at the lower sternal border. There are no murmurs. Which of the following is the most likely underlying cardiac change? Now, one thing in med school that you'll have to do is you'll have to upgrade your stick figures into anatomically correct, fully fleshed out diagrams like this. It's a secret that they don't teach you before you start rotations, but very important to master like I did here. Now, this person feels a thrusting impulse along their left sternal border. So we got some heart stuff and we also have some edema. This is a woman who presents to the clinic and she just can't breathe very well. Right? She's got her shortness of breath. So her leg swelling, all this should lead you to think of what's called a parasternal heave. And this is most often due to pulmonary hypertension. Now, where does the pulmonary hypertension come from? Well, usually it's in a smoker or somebody who has chronic lung disease. And so in this person, I believe they said COPD. Yep, so we got COPD. So low oxygen causes the pulmonary vessels to constrict. Usually that's a super good thing, but then this can cause chronic hypoxia. And so low oxygen causes the pulmonary vessels then to keep on constricting, keep raising that pressure, and it forces the right ventricle, because if you think of your heart, it's pushing, as the right side of her body, is pushing your lungs. It's forcing it to work harder and grow thicker. And so that thickened right ventricle then pushes against the chest wall, and that creates this palpable heave. So you have no murmurs necessarily, but you have the pressure and the overload, and you have that adaptation of the right ventricle. And so you can actually feel the impulse, and so it's going to be right ventricular hypertrophy caused by like some lung problems. Okay, so here are the trap answers. Left atrial hypertrophy, not really trap answers, just wrong. Mitral stenosis. That makes sense because left atrium, left ventricle stenosis here causes left ventricle hypertrophy. That's just displacement. Aortic aneurysm, not palpable externally. Beck's triad would have hypotension, JVD, and muffled heart sounds. You'd have the distant sounds, low voltage. Okay, hopefully that made sense as we kind of drew out this little patient here. That's question 16. Maybe one last thing before we just move on here. This is kind of like your rib cage, more or less, clavicle. So the right second interspace here, so 1, 2, right here, that's your aortic area. This is your pulmonic area. This is your epigastric right here by the subxiphoid. And then right here is the left ventricular area, the apex of the heart. And you remember this by saying all physicians can take money, but this is just like a better way to kind of visualize what's going on inside of the heart, right? Just in line with like the rib cage when you're palpating on people and trying to like listen to them. I should get on my stethoscope. Anyway, okay, let's move on to this next question. Researchers investigate the link between artificial sweeteners and pancreatic cancer. 500 patients are diagnosed with pancreatic cancer and they compare it to 500 healthy age sex-matched controls. Then they do the sweetener consumption that's assessed by interview. What study design does this represent? So they selected 500. And the way I like to think of this, just bear with me here, people who are diagnosed with pancreatic cancer. And so this is the odds ratio. And the way that you remember this, the best way to remember this, I tell you, is think about the odd people as what they select for. Those with pancreatic cancer. I'm not saying they were odd. I'm just saying for memory aid, it's helpful to think about odds ratio because in a case control with the O at the end, odd, O, case control, odds ratio is the odd people are selected first. That's the best way to think of this. I'm telling you, this is going to be a case control. And you just have to know that case control, like in my head, I just associated with O really strongly. I think it's because this O right here. I mean, there's an O there and there's an O in cohort. There are two O's. It makes me think of odd. Odds ratio, which then tells me that what you do first is you select the people who are odd, people who have pancreatic cancer first. And then you compare them to the other, in this case, 500 healthy aged, sex-matched controls. And then you assess the sweeteners. This is obviously going to be a case control. A case series, that's just a description of a bunch of cases. There's no control group or comparison there. The prospective cohort, so that follows the exposed versus the unexposed. This study starts with the outcome, the odds. So it's not it. Cross-sectional, that's like a snapshot. So this study looks back in time, not a single moment. So not cross-sectional. Retrospective cohort, that starts with the exposure and looks back at the outcome. So it's kind of like the opposite of a retrospective cohort. That's all there is to know about this one. Case control, O, odds ratio, start with the odd people. Next question. Okay, here's the next question. I can hear my dog, Charlie. Do you guys want to meet my dog real quick? He just got excited when I said his name. I'll show you my dog. This is Charlie boy. We went on a walk this morning, so he's well behaved. Charlie, can you sit? Who's a good boy? All right, so it sounds like this guy's got some poison ivy going on. Poison ivy affects 50 million people every single year. And the best treatment going to be corticosteroids because those guys inhibit phospholipase A2. And that's the enzyme that kicks off the entire arachidonic cascade. At least that's what Charlie told me. So no phospholipase, that means there's not going to be any prostaglandins, no leukotrienes, and definitely no cytokine storm. And so it's that upstream blockade that really sets your steroids apart. So your NSAIDs, your asthma medications, those would hit later targets like your COX or your leukotriene receptors, but your corticosteroids just shut off the entire, think of it like the entire faucet. It's just all shut off. So if they ever ask you for a mechanism of a poison ivy rash, then you shouldn't just be thinking of like the more downstream things like COX or leukotrienes. It's the inhibition of phospholipase A2. And that helps you stop the inflammation before it even starts. I'm going to take Charlie outside and then I will show you a graph of this. Okay, I think the camera's good. So the graph I want to show you kind of starts with the cell membrane. And here you have your lipooxygenase. And that will into your leukotriene. The cyclooxygenase is going to your prostaglandins over here, and these guys interface with tissue receptors. And so corticosteroids, these guys are therapy for allergic contact dermatitis. And where do you inhibit phospholipase A2? So you're cutting off the entire faucet. No downstream effects. So like your NSAIDs, except for XIB, are going to be non-selective COX inhibitors of 1 and 2. Xylutin is a selective inhibitor of lipooxygenase, and those are going to reduce inflammation. That's great. But steroids are even more upstream. That's 18. We're moving on. 19. Now for this one, I want to start with a question. What keeps your lungs from collapsing? Surfactant is super critical for reducing alveoli surface tension, and that's like going to mitigate that collapsing pressure. So we have a 30-week-old premature neonate delivered via emergency cesarean section within minutes of birth, tachypnea, nasal flaring, intercostal retractions. Arterial blood gas shows hypoxemia. Which best explains this? Answer is increased lung elastic recoil. Now, surfactant is made by your type 2 pneumocytes, and it lowers your surface tension inside of the alveoli and it keeps them open. And without it, those tiny air sacs just collapse like popped balloons, and it makes it just impossible for a baby to be able to breathe, to oxygenate. And when the alveoli collapses the lungs, what happens is they become super duper duper stiff and resistant to inflation. They just collapse, right? The lungs' elastic recoil is going to increase, and it increases like a whole bunch. So it basically like snaps shut after every single exhale. And that's why the babies are going to be grunting and flaring their nostrils and retracting their chest. They're just trying to reinflate, but they can't. Now, there's a key distinction I want to make here, because I know some of you are going to be a little bit confused about elastic recoil and lung compliance, because they seem like opposites kind of. But elastic recoil, that's the tendency of the lungs to collapse inward after they're stretched. So you stretch and then they recoil inwards. So it's that recoiling, which is going to be seen in this patient. It's like a rubber band. It snaps back. That's the elastic recoil. Compliance is the ease which they expand. So high compliance, super easy to inflate. That's the first part, and then the recoil comes back. And so in neonatal respiratory distress syndrome, which is what this patient has, it's a decreased surfactant, and so you have increased surface tension in the alveoli. And so they're going to collapse super readily, and then the increased elastic recoil is going to cause them to snap shut because the surfactant resist that. And so once they're collapsed, it takes a lot of effort and pressure to reopen them. Elastic recoil is the alveoli wanting to collapse. In respiratory distress syndrome, it's really increased. And then compliance is about how easily the lungs expand. So more negative pleural pressure would be needed to expand the lungs because of the poor compliance. So no, that's not the reason behind his respiratory difficulty. Increased surfactant production? No, it's the opposite. It's decrease the surface tension. Increased lung compliance, their collapse, so compliance is reduced. All right, last question. For this question, we have a 60-year-old woman presenting with fatigue, bone pain, and recurrent episodes of nephrolithiasis. Labs reveal serum calcium of 11.8, which is elevated, phosphorus, which is low, and elevated intact PTH. DEXA scan shows signs of cortical bone thinning. What is the most likely cause? It's going to be parathyroid adenoma, bones, stones, and psychiatric overtones. So it's primary hyperparathyroidism. It's chief cell adenomas. Now, up to 85% of all primary hyperparathyroidism is going to be caused by Yoji cell, chief cell adenoma. So we get a person who's got a lot of fatigue, bone pain, kidney problems, elevated calcium, low phosphates, and high PTH. And then you look at the exam on imaging and you see osteitis fibrosa cystica. That's going to be long-term unchecked bone resorption. And so excess PTH revs up your elevated PTH, elevated osteoclast activity. That dumps your calcium into the blood, and that promotes the renal calcium reabsorption, and it dumps the phosphate out. PTH, phosphate trashing hormone. And so you get stones, bones, groans, and psychiatric overtones. So it's going to be a parathyroid adenoma is the answer to this question. Okay, trap answers. Hypervitamin D shows high calcium and high phosphate but suppressed PTH. Multiple myeloma, hypercalcemia, but would also have anemia, fractures, and M spike. So I like it that you think of the high calcium, but also got the anemia and the M spike. Chronic kidney disease, hyperparathyroidism would be secondary though. That's if you have a kidney problem. So chronic kidney disease, you have a low GFR. And so you have decreased phosphate excretion. You can't get it out. And so the kidneys also fail usually if they're in chronic kidney disease to activate vitamin D because they have to do that too, right? Calcitriol. And, the mechanism of that is 1-alpha hydroxylase. That activity decreases, and then you have a decreased 1,25 dihydroxy vitamin D, all because that is decreased here. And so you have less vitamin D, and then you have decreased calcium absorption as well. So the parathyroid glands sense the low calcium, and they secrete more PTH. That's secondary hyperparathyroidism because of that low calcium first, and then PTH second. Okay, this has been MBME 26, Section 2, 11 to 20. We have tons of videos on this channel. Like and subscribe if you found this helpful. Let me know in the comments how I can improve these videos. We also have software that you guys can purchase. It's super amazing. I get messages. I should put them up on the video like these all the time. People saying they just passed their shelf exams because this works for shelf. It also worked for step 1 and for step 2 and step 3. People tell me all the time how helpful the eWorld Chrome extension has been. So be sure to check that out, like and subscribe. These videos definitely take a lot of time to create, and so I hope they're helpful. Leave a comment if you enjoyed it, and we'll see you guys in the next one.